Adult tumors and tumor-like conditions. Renal cell carcinoma. General features are renal cell carcinoma is generally a tumor of adults. Average age at diagnosis is 55 to 60 years. Many of the renal cell carcinomas occurring in the children have an appearance and behavior equivalent to those developing in adults, but a high percentage belong to the translocation associated types. Which are those types? We'll see below. The male to female ratio of adult renal cell carcinoma is 2:1. That means male are twice as more risk than females, and the incidence of bilaterally is 1% incidence. Cigarette smoking and high blood pressure are said to increase the risk for the development of the disease. Cigarette smoking and high blood pressures are the two risk factors for RCC. A rare familial form of the disease has been described. Conditions that may be complicated by the renal cell carcinoma are von Hippel-Lindau syndrome, acquired cystic disease. Half of the patients on a long-term dialysis develop an acquired form of a polycystic renal disease. So first of all, we'll talk about von Hippel-Lindau disease. Renal cell carcinoma occurs in 50% or more of the individuals with this autosomal dominant syndrome, which is also characterized by presence of CNS, usually cerebellar and retinal hemangioblastoma, cysts of kidney, liver and pancreas, clear cell tumors in a variety of sites including inner ear and pheochromocytoma. Renal cell carcinoma in these patients, that means von Hippel-Lindau disease patients, tend to be multiple and associated with a cyst, some of which showed atypical changes in the lining epithelium. The cysts, atypical cysts and renal tumors of these patients have a similar immunohistochemical profile. The cysts, typical, atypical cyst and a renal tumor of these patients have a similar immunohistochemical profile. The von Hippel-Lindau disease gene called as a von Hippel-Lindau has been identified at a chromosome 3p25.5. This tumor suppressor gene, von Hippel-Lindau gene is a tumor suppressor gene, is thought to exercise its action through the mechanism of transcription elongation instead of the usual transcription initiation. This tumor suppressor gene is thought to exercise its action through the mechanism of transcription elongation instead of usual transcription initiation. It is mutated in the germline of affected individuals, and in the VHL associated renal cell carcinoma, it is associated with the deletion of VHL in the wild type allele. Furthermore, VHL gene is also frequently mutated in the sporadic, that is non-papillary renal cell carcinoma, especially in the familial form, an alteration that can be detected in the formalin fixed paraffin embedded material. Furthermore, the VHL gene is also frequently mutated in the sporadic renal cell carcinoma, especially in the familial form, an alteration that can be detected in the formalin fixed paraffin embedded material. The marked degree of vascularization that often accompanies renal cell carcinoma and other pathological VHL defective tumors such as cerebellar hemangioblastoma is probably explained by the overproduction by the tumor cells of hypoxia inducible factors and the products of genes targeted by hypoxia inducible factors such as vascular endothelial growth factor, a potent endothelial cell mitogen, platelet derived growth factor which is PDG or transforming growth factor alpha, and erythropoietin. Acquired cystic disease. Half of the patients on a long term dialysis develop an acquired form of a polycystic renal disease. Half of the patients on a long term dialysis develop an acquired form of a polycystic renal disease. That means which are the patients are there no for the dialysis. Suppose 100 patients are there, in that 100% undergoing the dialysis ward. Now out of that 50 patients will develop a polycystic renal disease, which in a few cases has been complicated by the appearance of the renal cell adenoma and carcinomas. On this polycystic renal disease, there are renal cell adenoma and carcinoma chances. The tumors tend to be small, multiple and bilateral, and have a generally lower proliferative rate than their conventional counterparts. That means the renal cell carcinoma that is occurring in the acquired cystic disease due to the dialysis long-term therapy is very polite. It does not proliferate at the rate where classical renal cell carcinoma will proliferate, and these are very small, tiny things occurring in both the kidneys and multiple. They have also been described in the kidneys with acquired cystic disease of the patients who have not had dialysis. Papillary hyperplasia of epithelium of cysts in a consistent feature in these cases, and the likely pathogenetic basis for tumor development. Along these lines, a high proportion of these tumors have papillary features, even if their microscopic and cytogenetic features do not completely duplicate those of a sporadic papillary renal cell carcinoma. Still, a high proportion of these tumors, which are acquired cystic forms, have papillary features. Another common feature of the tumors arising in this setting is a intratumoral deposition of calcium oxalate crystals. Intratumoral deposition of calcium oxalate crystals. These tumors seem to have a unique immunohistochemical and molecular genetic profile. That means acquired cystic disease, which top of that where renal cell carcinoma has occurred. In these cases, the papillary features are most common, and intratumoral deposition of calcium oxalate crystals are seen. Adult form of polycystic kidney disease and multicystic nephroma, multilocular cyst. As with the preceding entity, the carcinoma in these cases accompanied and probably preceded by foci of papillary hyperplasia. The tumors are frequently multifocal and bilateral. So you can see in this figure that renal cell carcinoma developing in the adult form of polycystic renal disease. There is a polycystic kidney disease. Above that, the renal cell carcinoma has occurred. The tumor is very multicentric. You can see the multicenters here. Tuberous sclerosis. Although the classic renal tumor associated with this neurologic syndrome is neurological syndrome is angiomyolipoma. This means tuberous sclerosis. Although the classic renal tumor associated with tuberous sclerosis is a angiomyolipoma. That means renal tumor such as angiomyolipoma is associated with the tuberous sclerosis. There is also an increased incidence of renal cell carcinoma, sometimes seen in the intimate connection with the former. That means renal tumor, that is angiomyolipoma, is associated with the tuberous sclerosis. But tuberous sclerosis is always sometimes there is an increased incidence of renal carcinoma also. Cases of oncocytoma and chromophobe cell carcinoma have also been described in this setting. That means tuberous sclerosis association with the angiomyolipoma, renal cell carcinoma, oncocytoma and chromophobe cell carcinoma is all associated with the tuberous sclerosis. Now coming to the neuroblastoma, several cases have been reported of renal cell carcinoma developing in the children who had been previously treated for the neuroblastoma. Suppose the child is there who had got the neuroblastoma, he is treated. But as he grow as adult, he is found to be renal cell carcinoma patient. So this has been detected. Cytologically, these tumors had a oncocytoid features, and architecturally they displayed solid and papillary growth factor patterns. HLRCC syndrome, hereditary leiomyomatosis and renal cell carcinoma syndrome, hereditary leiomyomatosis and renal cell carcinoma syndrome. This autosomal dominant familial condition is characterized by the presence of cutaneous and uterine leiomyoma. HLRCC, which is a hereditary leiomyomatosis and renal cell carcinoma syndrome, is characterized by the presence of cutaneous and uterine leiomyomas and renal tumors. Most of the latter, that means renal tumors, have highly papillary features and are characteristically composed of cells with a large nucleus and a very prominent inclusion body like eosinophilic nucleolus. Malignant lymphoma. There have been enough reported cases of a coexistent renal cell carcinoma and malignant lymphoma to suggest to some authors the possibility of a causal relation between them. Malignant lymphoma is somewhere associated with the renal cell carcinoma. That's what they will suspect. One of the many peculiarities of renal cell carcinoma is its occasional regression in the absence of any type of treatment. Phenomena also documented with a gestational choriocarcinoma, malignant melanoma, neuroblastoma, and in a lesser proportion with several other tumors. Renal cell carcinoma is the most common recipient of a curious phenomena of metastasis of a cancer into another cancer. Lung carcinoma is the most common donor. Renal cell carcinoma is the most common recipient, lung carcinoma is the most common donor, the resulting macroscopic appearance leading to the interesting problems of interpretation. The opposite phenomena also occurs, the most spectacular example being renal cell carcinoma metastasizing into the CNS hemangioblastoma in patients with the von Hippel-Lindau disease. Clinical features of renal carcinoma usually presents with a hematuria, flank pain and abdominal mass. These are triads of diagnosis of renal cell carcinoma. However, these are not seen in all the patients. Only 9% of the patients these classic symptoms are seen. Other renal manifestations are weight loss, anemia, fever and symptoms caused by metastatic deposits in the 10% of the cases. Rare systemic paraneoplastic manifestations include leukemoid reaction, systemic amyloidosis, polyneuromyopathy, gastrointestinal disturbances, hepatosplenomegaly, hepatic dysfunction. These are other symptoms. Paraneoplastic manifestations include leukemoid reaction, systemic amyloidosis, polyneuromyopathy, gastrointestinal disturbance, hepatosplenomegaly and hepatic dysfunction. Hepatomegaly associated with the hepatic dysfunction. Hepatomegaly associated with the hepatic dysfunction in a patients with a renal cell carcinoma is known as a Stauffer syndrome. It is not due to metastatic deposits, and the main morphological change detected in the liver is sinusoidal dilation. In a case of the Stauffer syndrome, where renal cell carcinoma associated with the hepatomegaly, associated with the hepatic dysfunction, you cannot see metastatic deposits, but you can see sinusoidal dilation in the liver. Renal cell carcinoma can produce hypercalcemia as a result of the production of the parathormone like hormone or some other substances. Hypertension caused by the renin secretion, polycythemia secondary to the secretion of erythropoietin stimulating substance, gynecomastia as a result of a gonadotropin and a placental lactogen production, and a Cushing syndrome resulting from the secretion of the ACTH like substance. Secretion of prolactin, enteroglucagon, insulin like substance and a prostaglandin A has also been reported. In general, investigation of a suspected renal mass begins with an intravenous pyelography and is followed by USG, CT scan, MRI. Following the advent of the latter three techniques such as a CT scan, MRI, ultrasonography, the role of the renal arteriography and inferior vena cavogram has greatly diminished, and their use is reserved for special circumstances. With the increasing use of these modalities, the number of incidentally found renal cell carcinomas has increased substantially. In expert hands, core needle biopsy has been shown to provide adequate diagnostic material in about 80% of the cases. Now coming to the morphological features, grossly most renal cell carcinomas are well delineated and centered on the cortex. On occasion, only a small portion of connected with the cortex, the bulk of the tumor appearing as an extrarenal mass. Extension to the renal pelvis occurs only late in the course of the disease. In approximately 5% of the cases, multiple tumor nodules are seen scattered throughout the organ. In most of these cases, there is evidence of a polyclonality, suggesting an independent origin. The larger the tumor, the more likely will there be satellite nodules. In a typical case of renal cell carcinoma, the cut surface shows a solid golden yellow tumor sharply separated from a surrounding tissue by a fibrous pseudocapsule. The common occurrence of the hemorrhage, necrosis, calcification, cystic change, result in the variegated appearance that is so characteristic of this neoplasm. A remarkable range of color may be seen. However, in the presence of a white, finely granular tumor in the kidney, the diagnosis is likely to be something other than the renal cell carcinoma. A remarkable range of color may be seen in the renal cell carcinoma. However, in the presence of a white, finely granular tumor in the kidney, the diagnosis is likely to be something other than the renal cell carcinoma. You can see this in the gross. On occasion, the cystic degeneration is so advanced that a mural nodule remains as the only evidence of a real nature of the lesion. Sometimes even this disappears and the diagnosis is made only on the microscopic examination. On occasion, cystic degeneration is so advanced that a mural nodule remains as the only evidence of the real nature of the lesion. Sometimes even this disappears and the diagnosis is made only on the microscopic examination. Cortical cysts composed of a thick fibrous, often partially calcified capsule and containing a grumous yellow necrotic material represent, in most cases, necrotic renal cell carcinoma. Renal cell carcinomas with extensive cystic degeneration are designated by some as a cyst adenocarcinoma. Renal cell carcinomas with extensive cystic degeneration are designated by some as a cyst adenocarcinoma, but they should not be viewed as a special tumor type. More distinct are the low-grade tumors described as a multilocular cystic renal cell carcinomas, which are well demarcated multicystic lesions containing variably sized aggregates of tumor cells. You can see this here, A and B. In the B there are hemorrhages. In the A you can see that there is necrosis, there is well demarcation. So what they are telling is A and B gross appearances of renal cell carcinoma. Both tumors are relatively well circumscribed and variegated with a combination of cystic, solid and hemorrhagic areas. The tumor shown in the A has a bright yellow color, whereas this is having a bright yellow color, whereas B has extensive areas of necrosis. Other gross appearances of the renal cell carcinoma, the tumor shown in the A is a well circumscribed and relatively homogeneous. This is relatively homogeneous. Whereas B is almost entirely necrotic. This is entirely necrotic. This is homogeneous, this is necrotic, this is hemorrhagic. C grows outside the kidney and is markedly hemorrhagic, and D involves almost entire kidney and extends into the renal vein. You can see the extension of the renal vein in this here. The main differential diagnosis is with a cystic nephroma, a tumor type with which they may be related. Their prognosis is extremely favorable to the point that some authors have proposed to rename them as a multilocular cystic renal cell neoplasm of a low malignant potential. This is a renal cell carcinoma with a multilocular gross appearance. This you can see multilocular gross appearances of the renal cell carcinoma. So the main differential diagnosis is with the cystic nephromas, a tumor type with which they may be related. Their prognosis is extremely favorable to the point that some authors have proposed to rename them as a multilocular cystic renal cell neoplasm of a low malignant potential. Microscopically, the tumor cells of a clear cell carcinoma are large and appearance of a cytoplasm ranging from optically clear with sharply outlined boundaries, which are also called as a vegetable cells, to deeply granular with many transitional forms. Some authors have divided renal cell carcinoma into clear cell and a granular cell types on this basis, but it is doubtful whether the distinction is warranted. Tumors predominantly composed of a granular cells are sometimes called as a chromophilic. Tumors predominantly composed of granular cells are sometimes called as a chromophilic, in contrast with the chromophobe tumors discussed in the next section. Since practically all types of the renal cell tumors can exhibit a granular cytoplasm, and since other authors have used the term chromophil as synonym for papillary renal cell carcinomas, it is probably best to avoid this qualifier altogether. The cytoplasm may also contain hyaline droplets, phagocytosed blood pigments, other lysosomal granules, resulting in a brown pigmentation, and exceptionally Mallory-like bodies or a melanin. The clear cell appearance of the tumor cells results from the accumulation of the glycogen because of abnormalities of the carbohydrate metabolism. There is abnormality in the carbohydrate metabolism, that's why there is glycogen deposition, that's why these are clear cell. And also fat, which can be easily demonstrated with the pus and the oil red O stain respectively. Cytoplasmic mucin is nearly always absent. Tubular papillary cystic formations may be present. The nuclei are generally centrally located. Their size, chromatin pattern and the nucleolar appearance vary notably from case to case, this constituting the main basis for microscopic grading. Occasionally, scattered bizarre nuclear forms are seen in otherwise typical tumors, a phenomenon similar to that more commonly seen in the endocrine neoplasms and which should not be equated to the sarcomatoid or anaplastic transformation. Architecturally, most renal cell carcinomas show evidence of a tubular differentiation, which is called as a glandular differentiation. Hence, their alternative designation as a renal adenocarcinomas are called. Architecturally, most renal cell carcinomas show evidence of a glandular differentiation, so that's why renal adenocarcinoma entity exists. In the usual case, however, the pattern of growth is predominantly solid with the formation of large nests of tumor cells separated by stroma that is characteristically endowed with prominent sinusoid like vessels. Large sections or multiple sections usually show diverse pattern in the same tumor, a feature that renders subclassification based on the morphological patterns offers little significance, except for the types described in the following discussion. So this is the figure 17118, A and B, renal cell carcinoma, clear cell type. A is diffuse pattern of growth with the entrapment of glomerulus. Diffuse pattern of growth. There is diffuse pattern of growth with entrapment of a glomeruli. A high power view showing the optically clear cytoplasm and sharply outlined cell membrane. Sharply outlined cell membrane and clear cell cytoplasm. The stroma of renal cell carcinoma is a nondescript and in general not as abundant as in collecting duct carcinoma or a transitional cell carcinoma. A lymphocytic infiltrate, mainly composed of a T cell of variable degree, is present. Cases have also been described in which the red blood cells in the stroma form clusters. Red blood cells in the stroma form clusters, resulting in the myospherulosis like appearance. We have seen several cases in which a low grade renal cell carcinoma made up of a well differentiated tubular glands lined by clear cells was surrounded and closely intermingled with abundant vessels related smooth muscle bundles. Similar cases have been reported by others, some authors raising the possibility that this is a distinct tumor type and not a variant of the clear cell carcinoma. So that we have seen several cases in which a low grade renal cell carcinoma made up of a well differentiated tubular glands lined by clear cells was surrounded and closely intermingled with the abundant vessels related smooth muscle bundles. This is a different entity. Coming to the electron microscope features. Ultrastructurally, the clear cells are seen to contain abundant glycogen, variable amount of fat, scanty organelle, long microvilli on the apical surface. On the apical surface, there are long microvilli and numerous cell junctions. In the granular cells, organelle are more numerous and glycogen and fat are more scanty. Rarely, myelinoid, lamellated cytoplasmic inclusions are found. Variable numbers of mitochondria are also seen, reaching their highest concentration in the tumors with oncocytic features. Histochemical and immunohistochemical features. The features here described apply mainly to the prototypical renal cell carcinoma, generally known as a common or a conventional, that is that composed of a clear or a granular cell, whereas those associated with the variants are mentioned in the subsequent section in the connection with them. Immunohistochemically, renal cell carcinoma shows reactivity for epithelial markers such as keratin, EMA and CEA. IHC of a renal cell carcinoma show reactivity of epithelial markers such as keratin, EMA, that is MUC-A, MUC1 and carcinoembryogenic antigen. Keratin, EMA and CEA. The differential expression of keratins by the various tumor subtypes is of assistance in their differential diagnosis despite some degree of overlapping. The keratin is what differs in the various carcinomas in the subtype of renal cell carcinoma. The keratin usually expressed by the clear cell type of renal cell carcinoma are 8 and 18 in the clear cell. In the clear cell type 8 and 18, clear, 8 and 18, clear means 8 and 18, clear. You can see how you can remember this one is 8 is written like this, no, and 18 is written like this. So these are the clear areas where you can find clear cell carcinoma, keratin 8 and 18, that is of a simple epithelial type. Clear cell carcinoma is a simple epithelial type. Co-expression of keratins and vimentin is the rule, a feature not present in the normal tubular cells. Normal tubular cells will not express keratins as well as a vimentin. Other antigens detected in the cells of a renal cell carcinoma are a brush border membrane villi or villin. Villin is also seen in the some type of a renal cell carcinoma, alpha-1 antitrypsin, alpha-1 anti-chymotrypsin, and S100 protein, particularly in the alpha subunit, Lewis blood group isoantigens, and aldolase C isoenzyme. Two forms of enolase isoenzymes, angiotensin converting enzyme and angiopoietin like 4, Tam Horsfall protein, galactin 1 and 3, CD10, several CD44 isoforms, CD68 epidermal growth factor, hormone receptors, MUC1 mucins, and trefoil factor 1 protein, beta defensin 1, parvalbumin, MUC3 parathormone related protein, erythropoietin, pre-albumin, transthyretin, carbonic anhydrase 9, aquaporins, a family of water channel proteins, PAX2, PAX8, that is a nuclear transcription factor in renal development. A transcription factor in the renal development is a PAX2, PAX8, and a von Hippel-Lindau gene product. Exhaustive list of IHC. The lectin binding pattern is similar to that of normal proximal tubules. There is an altered pattern of a major histocompatibility complex expression. In addition, a variety of monoclonal antibodies against various defined and undefined epitopes of renal cell carcinoma, such as renal cell carcinoma markers, human gamma glutamyl transpeptidase, have been evaluated for their potential diagnostic utility. From the standpoint of a differential diagnosis, the choice of the markers to use depends on the specific situation at hand. That is, whether one is trying to decide to which subtype a given renal cell carcinoma belongs to, or whether a given clear cell carcinoma in an extrarenal site represents a metastasis of a renal cell carcinoma or not. In regard to the latter, that is representation of a renal cell carcinoma in some other parts of the body, the most useful positive marker are the co-expression of keratin and vimentin and the positivity of a CD10. So, in the scenario where a given clear cell carcinoma in an extrarenal site represents a metastasis of renal cell carcinoma, you can go for keratin and vimentin as IHC markers along with the positivity for CD10. Keratin, vimentin, CD10. It is, however, the negative markers that are of a greatest use depending on the circumstance to width. One, in the differential diagnosis with the adrenal cortical carcinoma, the fact that renal cell carcinoma is a negative for inhibin A and A103. So, adrenal cortical carcinoma, the fact that renal cell carcinoma is negative for inhibin A and A103. 2, in the differential diagnosis with a clear cell carcinoma of the ovary, the fact that the renal cell carcinoma is usually negative for keratin 34 beta E12 and CA125. So suppose you are doing a IHC where there are clear cells in the ovary. In that case, if you do IHC for keratin 34 beta E12 and CA125, if these come negative, then it is not a clear cell. If these come negative, that means clear cell carcinoma of the ovary, renal cell carcinoma is usually negative for keratin and CA125. That means ovary daga clear cell carcinoma, if it happens, then it will be negative for CA125 and keratin 34 beta E12. In the differential diagnosis with a clear cell carcinoma of the thyroid, the fact that renal cell carcinoma is negative for thyroglobulin and TTF1. In the differential diagnosis with a mesothelioma, the fact that renal cell carcinoma is negative for calretinine, mesothelin and CK5 and 6. So in the case of adrenal cortical, inhibin and A103 is negative. In case of the ovary, keratin 34 beta E12 and CA125 is negative. In case of carcinoma of a thyroid, renal cell carcinoma, thyroglobulin and TTF1 is negative. In the differential diagnosis of a mesothelioma, renal cell carcinoma is negative for a calretinine, mesothelin and CK156. It is actually embarrassing that for a tumor arising from a cell type that produces so many proteins, a truly specific and a sensitive marker is still wanting. From a histogenetic standpoint, the application of these various markers to renal cell carcinoma has by and large supported the long held impression that most examples of this tumor differentiate in the direction of a proximal renal tubules. Coming to the molecular genetic features, the notable features of a genetic aspects of a renal cell carcinomas is that in contrast to the epithelial neoplasm in most other organs, there is a very close relationship with the various morphological subtypes, which can be investigated by the conventional cytogenetics, PCR based restriction fragment length and polymorphism, restriction fragment length polymorphism RFLP screening techniques, FISH and microsatellite analysis, or more recently single nucleotide polymorphism SNP. This section will only deal with the molecular genetics of a clear cell carcinoma, while those of other types of the renal cell carcinoma will be dealt with the subsequent sections in the conjunction with the clinicopathological description. A distinctive cytogenetic abnormality found in most cases of the clear cell renal cell carcinoma is terminal deletion of a short arm of chromosome 3 beginning at 3p13. Clear cell renal carcinoma is terminal deletion of a short arm of chromosome 3 beginning at 3p13. Since this abnormality is not found in other types of the renal cell carcinoma, its detection can be utilized to aid in such differential diagnosis. The von Hippel-Lindau gene on a 3p25, 26, 3p25 and 26 is typically implicated with the inactivation of both the copies. But other genes on a 3p may also play a role, such that FHIT 3p1112, RAS F1A 3p2122, DRR1, 3p2122. Less common alterations are losses of a chromosome 6p, 9q, 10q, 13q, 14q, 17q, 6, 9, 10, 13, 14, 17, 6, 9, 10, 13, 14, 17. These are less common alterations, are losses of these chromosomes are less common alterations. The molecular changes have shed light on the pathogenesis of some clinical and morphological features of a clear cell carcinoma, as well as provided the basis for the design of various targeted therapies. The VHL protein normally binds with the HIF-A, that is hypoxia inducible factor alpha subunit, resulting in the degradation of HIF-A. Suppose this is a VHL protein. This will bind with the HIF, that is hypoxia inducible factor alpha subunit, and this will what it will do, resulting in the degradation of the HIF alpha. With loss of VHL protein in the clear cell renal cell carcinoma, what happens is HIF-A accumulates. So in the renal cell carcinoma, what happens in RCC, this will be VHL will be lost. Then what happens is HIF will increase. There is no more cancellation, and HIF-A will increase. This will lead to the accumulation of HIF-1, HIF alpha, resulting in the activation of variety of hypoxia inducible genes, and hence increased production of their products. These include vascular growth, endothelial growth factor causing the vascular proliferation, platelet derived growth factor causing the fibroblast transformation, promoting the vascular pericytes, and autocrine growth stimulation, transforming growth factor alpha, activation of a renal cell epidermal growth factor receptors, glucose transporter which has a GLUT1, and metalloproteinases degrading extracellular matrix and hence promoting the metastasis, and erythropoietin causing the polycythemia. So what really happens is normally VHL, what it will do, it will bind to the HIF alpha and inhibits it. In cases of RCC where VHL is not there, then HIF will increase. That will lead to various activations. Suppose if it activates VEGF, then there is a vascular proliferation, platelet derived growth factor B causing the fibroblast transformation, vascular pericytes and autocrine growth stimulation, TGF alpha activating renal cell epidermal growth factor receptors, GLUT1 will glucose transporting, metalloproteinases degrading extracellular matrix, hence promoting the metastasis. What they will do is, this is a matrix, right, metalloproteins. What they will do, these metalloproteinases will degrade this, that's why leading to the metastasis. And erythropoietin causing the increased in HB, leading to the polycythemia. Furthermore, AKT-mTOR pathway can also affect HIF alpha. Since mTOR normally promotes translation of HIF alpha, targeted therapy may therefore utilize tyrosine kinase inhibitor for VEGF, tyrosine kinase inhibitors for VEGF receptor and PDGF receptors such as sunitinib and sorafenib, inhibitor for mTOR such as temsirolimus, antibody targeting VEGF bevacizumab. Other microscopy types. Several types of the renal cell carcinoma exist that deserve to be segregated from the conventional clear cell type on the basis of their cytoarchitectural features, especially in these are associated with a distinct cytogenetic and behavioral properties. However, it remains to be seen whether these differences are as sharp and consistent as implied by some of the concurrently proposed classification schemes, or whether As has happened before many times into many other organs, further studies reveal an array of hybrid and transitional forms. Renal cell carcinoma of a papillary type. Note the neutrophilic infiltrations. They are saying there is a neutrophilic infiltrations in the papillary type. Papillary type में what is happening? Neutrophils are infiltrating. Suppose this is a neutrophil. This is infiltrating the clear cell. So that's how the papillary will form. Papillary renal carcinoma. Papillary renal carcinoma comprises about 15% of all renal cell carcinomas. It is so sometimes see papillary renal carcinoma comprises 15%. Which is the most common? Yes, clear cell. So papillary renal carcinoma, it is sometimes also called as a chromophil, but as already discussed, it is better to avoid this synonym. Renal tumors arising in a patients on a chronic hemodialysis tend to be papillary type. So chronic hemodialysis, these are always not always, most of the times these are papillary renal carcinoma. Some cases of papillary renal cell carcinomas are hereditary also. Not only hemodialysis, they can be hereditary, and these have found to be associated with the germline mutation c-MET. So Papa chromosome Y, loss of chromosome Y. Papa is a man. c-MET. Papa is very aggressive. So these are the mnemonics you have to remember. Papillary renal cell carcinoma is characteristically hypovascular on a radiographic studies, and grossly it may exhibit extensive areas of necrosis. Papillary, Papa is extensive, aggressive, so that's why necrosis. These are necro. It is more likely than conventional renal cell carcinoma to be localized to the kidney, but also more likely to be multicentric or a bilateral. Microscopically, complex papillary formulations are seen, often accompanied by prominent stromal infiltration by neutrophils. Complex papillary formations are seen, often accompanied by prominent stromal infiltration of these neutrophils and foamy macrophages. Samoma bodies may be numerous samoma bodies you can see. Okay, samoma bodies, one more mnemonic. So Papa is a loss of Y chromosome. Papa is very aggressive, so that's why he will go give necrosis. Papa is a samoma body, and c-MET also, right? Okay. The nuclear grade is variable. Immunohistochemistry, and in contrast with the conventional renal cell carcinoma, there is a consistent expression of keratin 7. So P you will write like this, no? Just turn it off and become 7. Cytogenetically, the most consistent aberrations are a trisomy of 3q, 7, 8, 12, 16, 17 and 20, and loss of Y chromosome. In contrast to the conventional renal cell carcinoma, there is no loss of 3p. 3p loss is not there in the conventional, but in this papillary there is a 3p loss. It has been proposed that papillary renal carcinoma can be further subdivided into two types. Papillary can be subdivided into type A and type 1 and type 2, but remember the CAP protocol what is it telling is, don't differentiate between type 1 and type 2, because here you can see this. Here the latest CAP protocol, what it is telling is that Papillary type 2 is vomited. Papillary type 2 is vomited, leading to the specific entity to be enumerated, like FH deficiency, MIT family, or ALK family. So just don't use papillary type 2. Don't use type 1 and type 2 from now onwards. Just stop using type 2 and enumerate the specific, be very specific, they are telling. So as we have come this, we'll discuss the latest CAP protocol, right? Okay, histological grades of WHO, this is in the 2025, right? There are grades, grade 1, grade 2, grade 3, grade 4 and grade X. So 4 grades are. One grade is a nucleoli absent or a inconspicuous even in the 400X. So one is telling 400X, the nucleoli is not there. In a 400X, if nucleoli is visible, then it is a grade 2, but not prominent in the 100X. In nucleoli is a conspicuous at 100X, is grade 3. Extreme nuclear polymorphism is there, multinucleated giant cells are there, and a rhabdoid and a sarcomatoid differentiation is there, then it is directly grade 4. Grade X is cannot be assessed. So grade 1 is a 400X not seen, nucleoli is not seen or inconspicuous. In grade 2 is 400X, nucleoli is conspicuous, seen but conspicuous. In grade 3, nucleoli is conspicuous at 100X, conspicuous, present but is conspicuous at 100X. And grade 4, there is a pleomorphism, nuclear pleomorphism, multinucleated giant cells are there. You see, these are the multinucleated giant cells, and rhabdoid sarcomatoid differentiation is there. This is histological grading. TNM classification, Y means post neoadjuvant therapy, R means recurrence. PT staining, 0 means no evidence of primary tumor. There are 3 PT or 4 are there. TNM staging mein T4 are there. T1 means tumor is less than or equals to 7 cm in the greater dimension, limited to the kidney only, right? In P2, what happens is it is greater than 7 cm but limited to kidney. In PT3, tumor extends to the major nephric veins and tissues but not in the ipsilateral adrenal gland. Ipsilateral adrenal glands, not beyond the Gerota's fascia. Okay. So it is extending into the renal vein and the perinephric tissues, but not to the adrenal, not to the Gerota's fascia. T4, what happens is Gerota fascia is invaded, including the contiguous extension, non-contiguous and contiguous extension, 2 types are there. In that, contiguous extension into the ipsilateral adrenal gland and Gerota's fascia. So in the T1 we have studied it is less than or equals to 7 cm and limited to the kidney only, right? So in that we have A, B, okay. If tumor is less than 4 cm, then it is A. If it is greater than 4 cm, less than 7 cm, it is B. In P2, we have studied it is greater than 7 cm but limited to the kidney. So we have A and we have B. 7 to 10 cm in the greatest dimension is A, and greater than 10 but limited to the kidney is B. In 3, we have A, B and C. What was 3? 3 means there are major veins and perinephric tissue, there is extension, but not to the adrenal gland and not to the Gerota's fascia. So only to the perinephric tissues and the renal vein. In this we have A, B and C. Tumor extends into renal vein or its segmental branches, or pericalysis system, invades perirenal and renal sinus, but not beyond Gerota's fascia. Tumor extends to the B is tumor extends just below the diaphragm. Suppose this is diaphragm, just below the diaphragm. Just above the diaphragm is C. Just above the diaphragm is C, just below the diaphragm is B. Okay, this is we are talking about vena cava, right? In A we were talking about a renal vein. Here in this two we are talking about vena cava. Vena cava, in that also diaphragm, we will see the diaphragm. Diaphragm, if it is below the diaphragm it is B, if it is above the diaphragm it is a C in the vena cava. Okay. In T4, Gerota's fascia is invaded and ipsilateral adrenal gland. N, we have N classification. N0 means no regional lymph node, N1 means regional lymph nodes. M1 is distance metastasis, non-contiguous adrenal gland involvement, also M1. What is non-contiguous? Perhaps. So here we have studied it is a contiguous. Here we are studying it is a non-contiguous. What is the difference? See, this is a kidney, right? This is adrenal gland. So there is a contiguous spread. That means the M staging is not changing, just T staging is changing. That means just contiguously it is spreading, not going in the vein. M, what happens in this vein, it will go and non-contiguously it will spread to the adrenal gland, that is non-contiguous spread. So that's why M staging will change. So histological classifications, WHO 5th edition, clear cell renal tumor, papillary renal tumor, oncocytic and chromophobe renal tumors, and collecting duct tumors, other renal tumors are there. In the clear cell renal tumors, multilocular cystic renal neoplasm of a low malignant potential, as we have discussed in there, and clear cell renal carcinoma, papillary renal cell carcinoma, chromophobe renal cell carcinoma, and oncocytic tumors of the kidney. Collecting duct carcinomas. In other renal tumors, there is a clear cell papillary, clear cell and then papillary renal carcinoma, mucinous tubular spindle cell carcinomas, tubulocystic renal cell carcinoma, acquired cystic disease associated renal carcinoma, and eosinophilic solid cystic renal cell carcinoma and renal cell carcinoma, NOS. Molecularly defined renal cell carcinomas are a TFE3 rearranged renal cell carcinoma, TFE3 rearranged renal cell carcinoma, TFEB altered renal cell carcinoma, ELOC mutated renal carcinoma, fumarate hydratase deficient renal cell carcinoma, succinate dehydrogenase deficient renal carcinoma, ALK rearranged renal cell carcinoma, and SMARCB1 deficient renal cell carcinoma. There are fumarate hydratase deficient, succinate dehydrogenase deficient, then SMARCB1 deficient. These are three types, and ALK rearranged, TFE3 rearranged, altered are TFEB, ELOK mutated. These are the molecularly defined renal cell carcinomas. In clear cell carcinoma, papillary carcinoma, we can use the gradings. So we'll continue from here. Type 1 in which the papillae are, this is a old one, right? Old one. So we'll just study old one and just forget it. Type 1, in which the papillae are lined by a single layer of cells. Papillae are lined by single layer of cells with a scanty pale cytoplasm, and type 2, in which the papillae are lined by pseudostratified epithelium composed of cells with abundant acidophilic cytoplasm. According to this scheme, it is type 1 tumors that are accompanied by a foamy macrophages and a samoma bodies. Foamy macrophages and samoma bodies at type 1, and that are immunoreactive for the keratin 7 and a MUC1. Keratin 7 and 1 is reactive to the keratin 7 and MUC1. They may also have a different cytogenetic abnormalities, but their clinical outcome is similar. It is questionable whether these are truly two distinctive subtypes or whether they represent instead different grades of the same tumor, lower for type 1 and higher for type 2. It is very confusing, but in latest WHO they have told grade 2, just vomit it out, just say the specific type based on the IHC. As a group, papillary renal cell carcinoma has a better prognosis than a conventional renal cell carcinoma. Although papillary renal cell carcinoma is currently regarded as a distinct subtype, it is far from being homogeneous entity at any level. Morphologically, in addition to the alleged two subtypes above described, there are solid variants with a rare papilla similar to the collecting duct carcinoma, variants in which papillae are lined by oncocytes, sometimes with an inversion of the nuclear polarity, and variants in which the tumor cells have a clear cell cytoplasm and with a chromosome loss of a 3p. The latter have been generally regarded as a conventional clear cell renal cell carcinoma, that is a loss of 3p, with a papillary pattern of a growth rather than the papillary renal cell carcinoma. So 3p loss is said as a conventional clear cell renal cell carcinoma with a papillary pattern of a growth rather than papillary renal cell carcinoma with a clear cells. But some authors view them as a distinct tumor type. It should also be realized that a papillary renal cell carcinoma, like all other types, can undergo anaplastic and sarcomatoid change. So we'll discuss collecting duct carcinoma in the next video.